I wanted to start off with some definitions. Sensitization. So sensitization is the development of IgE. It's when the body produces IgE antibodies against a substance. And then these same specific IgE antibodies adheres to certain cells in the body, mast cells, basophils. And when the person is then re-exposed to the allergen that caused the production of the IgE antibodies, you get release of chemical mediators from the mast cells and basophils, histamine, prostaglandins, etc. And that's what causes the symptoms such as rashes, wheezing, and vomiting. Allergic rhinitis is due to allergic inflammation. And on the left, you see a schematic looking at what happens with allergic inflammation. We have an early phase that occurs 5 to 15 minutes after exposure to an allergen. Mediators that are released, histamine, leukotrienes, TNF, etc. And then you get cellular infiltration. You get eosinophils, basophils, monocytes that come into the area. And then you get this late phase reaction that occurs over 3 to 12 hours. Now we're talking about allergic rhinitis here, but this same sort of schematic could be seen in the lungs, the skin, etc. And you may have heard of the one airways hypothesis, which talks about allergic inflammation in the upper airways then tracking down into the lower airways. So we do know that allergic rhinitis is associated with inflammatory disorders of both the upper and lower airways. It can predispose to otitis media and sinusitis. Allergic rhinitis and asthma often coexist in the same individual. And to give you some perspective, 80% of asthma patients have allergic rhinitis. 40% of rhinitis patients have asthma. It is a chronic disease, again, mediated by early and late phase allergic response to environmental allergens. It's a systemic inflammatory process, and the typical symptoms are characterized by pruritus, sneezing, rhinorrhea, and nasal congestion. The eye symptoms are itchy, watery red eyes, and you can sometimes get itching of the ear canals and palate. These are the various aeroallergens or inhalant allergens that we come across in our specialty. For pollens, we deal with trees, grasses, weeds, including ragweed, spores, molds. And so when you listen to the weather report, you're going to be listening for pollen counts and spore counts. There are indoor and outdoor molds, both of which we test for. Furry pets, cat, dog, guinea pig, rabbit, and others. And from experience, I know that cat and guinea pig are two of the pets that cause the most severe symptoms. Dust mites, and then you get into the rodents and pests, cockroach, mouse, and rat. Mouse being a problem in laboratory workers who handle mice as part of their job. On physical exam, there are certain things that you see in allergic rhinitis. And so allergic shiners is a big one, and this is due to vascular congestion of the blood vessels that surround the eyes, the nasal passages, the sinuses. You get transverse nasal crease from rubbing so much. You get these pale, boggy nasal turbinates, and then you get the classic allergic salute that we see oftentimes in children when they present to our clinic. The testing involves IgE testing, and there's two types of testing for IgE. There's skin testing, and then there's what's called immunocap testing. Skin testing is epicutaneous. It's a prick technique or a scratch technique. More invasive is intradermal testing, which is the next step. If warranted, it's more sensitive, more invasive, more difficult to perform, and requires a more diluted extract. There are positive and negative controls. When we get a response, we look for swelling, as you can see here. We measure it in millimeters. This is the wheal reaction. And any surrounding redness around it is called the flare reaction. And so if there's a wheal greater than 3 millimeters after the saline control is subtracted, it's considered positive. Now, immunocap testing is a newer term that we use. RAS testing is the older, archaic term. It's a more sensitive in vitro assay that picks up allergic antibodies, and it's also known as specific IgE testing. For the purposes of environmental allergies, skin prick testing is more sensitive, and so is the one that we tend to use the most. Here are the prickers or the lancets that we use to skin test with. These are dilute extracts that we use to scratch the skin with. Here you can see a small drop of the allergen extract being placed on the skin, and then the skin is gently scratched through the drop. And if the skin reddens and swells, then the test is read as positive, and allergy to that substance is considered probable. So what are the advantages and disadvantages of skin prick testing? The advantage is that skin prick testing has a greater than 95% negative predictive value, so that if it's negative, we're fairly certain that it is negative. It is more sensitive than immunocap testing, but because it's more sensitive, it can pick up a lot of false positives as well. So the presence of specific IgE may be without clinical relevance. Its lack of standardization, and it does not help with non-IgE mediated reactions. So in a nutshell, skin testing is used to screen for environmental allergies because of its good sensitivity. It is more sensitive at detecting an environmental allergy than immunocap testing, but immunocap testing can be used in patients who cannot easily stop antihistamines or those with diffuse eczema. I just want to touch upon non-allergic rhinitis. Many times we get patients that come into our clinic who we believe may have allergies. We do skin testing and they actually are negative. So non-allergic rhinitis are chronic nasal symptoms that are not due to allergies. It's usually nasal congestion and postnasal drip. If you have profuse watery rhinorrhea, that can be more indicative of vasomotor rhinitis. They have limited sneeze or ocular symptoms, and allergic rhinitis and non-allergic rhinitis often can coexist. It's due to sensitivity to irritant exposure, so the treatment would be environmental control, limiting cigarette smoke, fumes, perfumes, things of that nature. The same medicines are used as those used in allergic rhinitis, and it's based on symptoms. The older antihistamines, such as Benadryl, hydroxyzine, may be more effective due to anticholinergic properties. So when would you want to refer to an allergist? You would refer if the allergic rhinitis symptoms are not relieved by environmental control and medicines. If the patient is requiring regular medicines and just does not want to take medicines anymore. If the patient is experiencing recurrent sinus infections. If the patient has significant allergic asthma. Or if the patient is considering allergen immunotherapy, also known as allergy shots, for some or all of these reasons. When would you want to refer to ENT? Chronic recurrent sinusitis, and meaning green nasal discharge, facial pain, fever, cough, not controlled by medications and in the absence of immune deficiency. Chronic nasal obstruction only, so without sneeze, without ocular symptoms, without rhinorrhea. If it's associated with obstructive sleep apnea symptoms, and if there's any structural or anatomical defect on exam, such as polyps, septal deviation, or turbinate hypertrophy. What is the general allergy management? So obviously you would avoid the allergen triggers. You want to use appropriate medications, and if warranted, you want to evaluate for immunotherapy, and always educate the patient. So in terms of our environmental control, what do we usually recommend? For dust mite allergy, we recommend encasements for the mattress and pillows, because we know that dust mites do live in the mattresses and pillows. Washing all bedding in hot water, removing any dust mite reservoirs, vacuuming but not by the patient, keeping any furry pets off beds because furry pets do carry dust mites and dust mites do like furry pet fur. You want to keep the humidity level less than 40%. And for furry pets, you want to remove the pet from the home, if at all possible. Keep outside or at a minimum out of the bedroom. You want to open windows to allow air exchange. And if the windows are closed, you want to use a HEPA air cleaner. For indoor mold, decrease humidity, use diluted bleach to remove any visible mold or mildew, remove carpets in the bathrooms, limit indoor plants and firewood. And for pollens, you want to keep the windows closed, run the air conditioner, shower, wash hair, and change clothes if outside for a prolonged period of time. In terms of treatment for allergic rhinitis, we use oral H1 antihistamines, first generations and second generations, although it's falling out of favor to use the first generations on a more day-to-day basis because of its shorter half-life. It wears off in 6 hours, and because it can be more sedating. It has anticholinergic properties as well because it crosses the blood-brain barrier more easily. The second generation antihistamines are the ones that we tend to use more often, Zyrtec, Claritin, Allegra. They're safer, they're more effective, they have anti-inflammatory properties. There are also local H1 antihistamines to the nose and to the eyes that we can use. They can make you sleepy, but they work well in conjunction with intranasal steroids, one being Astelin nasal spray. I usually like to prescribe Astelin, 1 squirt to each nostril once a day, followed 10 minutes later by the Flonase, 1 spray to each nostril once a day, depending on the symptoms, and that works very well. Intranasal steroids are much more effective than any antihistamine or decongestant for persistent rhinitis symptoms, including ocular, but especially nasal congestion. And some purists would say that all you would really need is an intranasal steroid and not necessarily antihistamines. And then there's also leukotriene receptor antagonists such as Singulair, which is recommended in rhinitis patients with concomitant asthma. There are local chromones and anticholinergics, intranasal and intraocular, that are used. They're well tolerated, but they have a very short half-life, and so it requires multiple administrations 4 times a day, so that makes it less effective and less feasible to use. There are also oral decongestants that are used, such as pseudoephedrine. Their short and long-term side effects can discourage the use in children, however, and so we don't routinely recommend that as well. There are intranasal decongestants that have very rapid onset of action and work very well. And so for a very short course, I would say 2 to 3 days or so, it may be used. But the problem with it is that with overuse, it can lead to rhinitis medicamentosa, which is rebound hypertrophy or sort of an addiction to the intranasal decongestant. So we kind of shy away from that as well. Now, this was a study that was performed in 6 to 11-year-old patients with seasonal allergic rhinitis, and they looked at the use of intranasal fluticasone, 50 micrograms and 110 micrograms, and they compared it to a placebo. And what they found is that with the Flovent or fluticasone nasal spray 110 micrograms once daily, there was significant reduction over a 2-week period in nasal symptoms. And so intranasal steroid monotherapy can be something that you start before you even add on an antihistamine, such as Zyrtec or Claritin or Allegra. There is a newer combination therapy that is out there. It's a combination of an intranasal antihistamine and a steroid, Astelin and fluticasone. It has a good safety profile, rapid nasal saline, nasal symptom relief, and greater nasal symptom relief than either intranasal steroid or antihistamine use alone, as you can see here. It's called Dymista, and it's fairly new on the market. Now, in terms of ocular allergy, I think this deserves a little bit of its own section because it is particularly bothersome in patients who do experience it. It's a spectrum of disorders with overlapping symptomatology and progressive severity, and it affects about 15 to 25% of the U.S. population. The triggers are the same as for allergic rhinitis, and the pathophysiology is the same as well. There's an acute phase and late chronic phase involving allergic inflammation. And so we break it up into the seasonal allergic conjunctivitis and the perennial allergic conjunctivitis. These are the most common. And then we have the vernal and atopic keratoconjunctivitis, which are rare but sight-threatening. And then I put in there giant papillary conjunctivitis, which I won't talk too much about, but it is sometimes clumped under the ocular allergy spectrum because the symptoms are very similar. However, it's not due to allergens per se. It's due to trauma or contact lens misuse. So here are pictures showing someone with seasonal and or perennial allergic conjunctivitis. It involves both eyes, very red and itchy and pruritic. And now turning our attention to vernal keratoconjunctivitis. This preferentially affects boys ages 5 to 15 years, and it initially presents in the spring pollen season, but can recur at any time. It's oftentimes associated with atopic diseases, so they may also have asthma or eczema or food allergies. 50% or more of these patients have some other atopic disease. There is intense itching of the eyes. There's photophobia, and we do believe that it's a T-cell mediated disease involving the cornea. So here are some pictures showing some of the signs of vernal keratoconjunctivitis. You can have ptosis of the upper lid. You can have what's called papillary hypertrophy, as you can see here, or cobblestoning of the eyelid. You have Tranta's dots here, which is very often seen, and this is due to a collection of epithelial and eosinophilic debris. And then you can get shield ulcers, which can be sight-threatening in the long run and lead to corneal ulcers, etc. Atopic keratoconjunctivitis is perennial, and it affects teens, early 20s. These patients have a history of eczema, and the activity parallels the activity of the skin. They oftentimes have very burning eyes, burning symptoms. They have corneal and or lid involvement. And so here you see a classic presentation of atopic keratoconjunctivitis. There's keratoconus, which is bulging of the cornea. You can get corneal ulcers as well, as in vernal. You get Tranta's dots also, and you get this palpebral eczema, with lid edema. So they, in addition to the ocular symptoms, have skin findings around the eyes. Now, I just wanted to also bring to your attention the non-allergic threatening eye disorders that can mimic allergic eye disorders. Acute glaucoma, herpes simplex, and other forms of keratitis, iritis, scleritis, episcleritis. And ciliary flush, as you can see here, is a red ring around the eyes, is a danger sign that's not seen in conjunctivitis, but is seen in the other non-allergic threatening eye disorders. So for ocular allergy, the topical treatments that we use are topical antihistamines, decongestants, mast cell stabilizers, NSAIDs, corticosteroids, cyclosporin, and then there are the ones that have multiple mechanistic agents, which are actually the ones that we tend to use more often. Combination of antihistamine and mast cell stabilizers. Azolestine is one, epinastine is one, ketotifen is one, and olopatadine is one. Last resort would be immunotherapy, subcutaneous immunotherapy versus sublingual immunotherapy. So now we're going to turn our attention to allergen immunotherapy. And so the indications for that are allergic rhinitis, allergic conjunctivitis, asthma, although this is a slightly controversial point, venom allergy, and it is not used for urticaria, drug allergy, food allergy, although there is oral immunotherapy studies that are being done, and eczema. So the mechanism of allergen immunotherapy is such that it causes a slow decline in specific IgE during immunotherapy. There is a rise in serum IgG blocking antibodies, IgG1, IgG4, and IgA. There is suppression of allergen-specific Th1 and Th2 cells, and we see a decrease in mast cell and eosinophil numbers over time. Also, once you re-skin test these patients, there is a decrease in skin test reactivity as well a couple of years out in treatment. So what are the requirements for subcutaneous immunotherapy? The patient should be evaluated by a board-certified allergist immunologist. There should be skin testing or immunocap testing that is done, whether it's skin prick testing and intradermal testing or just skin prick testing. It all depends on the scenario. And the positive tests should correlate with the symptoms of the patient. The patient should be unresponsive to environmental precautions and or medications. If they have significant ocular allergy, that is another indication. If they have severe allergic asthma, but know that these patients will be at a higher risk for having reactions during the course of the immunotherapy. They should be old enough to tolerate allergen immunotherapy, and that is at the discretion of the allergist. Time commitment, it takes about 3 to 5 years on average for the full course. And if there is no clinical response, we then discontinue. It should also be physician supervised in an office that is capable of treating anaphylaxis. This was a study called the Preventive Asthma Treatment Study, a seminal study looking at the prevention of asthma in children who were on allergen immunotherapy. They looked at 205 children with allergic rhinitis symptoms to birch and grass. They received immunotherapy for 3 years in those without asthma. It occurred in Denmark, Sweden, Finland, Germany, and Austria. And as you can see, in the subcutaneous immunotherapy group, there was a far larger number of patients who did not develop asthma while on treatment versus the controls. This was a p-value of less than 0.01. So suggesting that immunotherapy can prevent asthma in children. But again, a controversial point. Cost saving. So this was a study that was published in the Journal of Allergy and Clinical Immunology, looking at those who were on immunotherapy treatment and those who were not and receiving medications. And you can see at the various follow-up points that there was definitely a cost saving using allergen immunotherapy. I also want to talk about sublingual immunotherapy because this is a fairly new thing here in the United States. Sublingual immunotherapy has been used in Europe for quite a number of years, but it was recently approved by the FDA here in the United States. And there are 3 preparations that have been approved: Ocular, Grastek, and Ragwitek. It's once daily dissolving tablet in the mouth, underneath the tongue. Systemic reactions are very rare, has a very good efficacy in allergic rhinitis, 20 to 50% reduction in symptoms, which is similar to subcutaneous immunotherapy. For Ocular specifically, it's for the treatment of grass pollen-induced symptoms, and it's approved for ages 10 to 65 years. Grastek is for the treatment of grass pollen-induced symptoms, And Ragwitech is for the treatment of ragweed pollen-induced symptoms and for ages 18 to 65. The problem with sublingual immunotherapy, though, is that it's monotherapy, and it's not yet at the point where we're doing multiple allergen immunotherapy. So this is a nice table looking at the benefits, the shared characteristics and the differing characteristics between subcutaneous immunotherapy versus SLIT. So they're both effective for allergic rhinoconjunctivitis and allergic asthma. They're both disease-modifying in that it seems to prevent the development of asthma in patients with allergic rhinitis. They seem to prevent the development of new sensitivities in patients who are monosensitized, and there seems to be a persistence of benefit for several years even after you discontinue it. There's induction of regulatory T cells so that you're going from a Th2 allergic profile to a Th1 non-allergic profile. But where they differ is that SLIT seems to be a better side effect profile. The frequency and severity of systemic reactions are lower. There's a defined effective and ineffective doses for SCIT, but not for SLIT. And the proven effectiveness of multiple allergen extracts holds for SCIT, but not for SLIT. As you see, we only have ragweed and grass so far. I know that dust mite may be coming down the pipeline soon, but not yet available. So it seems that SLIT would be better for patients who are just monosensitized at this point. And the relative clinical efficacy remains to be determined. There have not been a good amount of head-to-head studies really comparing the clinical efficacy between subcutaneous immunotherapy and SLIT in randomized fashion. So if you choose to administer allergen immunotherapy in your office, you should obtain extracts from a trusted board-certified allergist. You should obtain clear instructions regarding the progression of dosing. Oftentimes, practices will take on patients after they've been built up to maintenance dosing and they're receiving it at least once a month. You may want to start allergen immunotherapy in your office once the patient is already built up and on maintenance dosing, as said before. You want a dedicated trained nurse to administer the immunotherapy, and there should be a 20 to 30-minute observation period afterwards, and the office should be equipped to treat anaphylaxis if the need arises. So that brings me to our next topic, anaphylaxis. What is anaphylaxis? It's an acute onset, multi-system, potentially fatal allergic reaction. And it's multi-organ, so skin findings would include urticaria, angioedema. Respiratory findings would include cough, wheezing, dyspnea. GI would be vomiting, diarrhea, abdominal pain. CVS or cardiovascular would be hypotension and shock, and then you would have headache for CNS findings. There is also 1 to 20% late phase reaction that can occur 8 to 12 hours after initial onset. The lifetime prevalence is 0.05 to 2%. It's most often seen in children and adolescents, most often from food, and in adults, most often from insect stings and medications. Less than 15 years of age, there's a male predilection, and greater than 15 years of age, there's a female predilection. So what's the pathogenesis? We sort of touched upon this, but here's your mast cell. You have IgE antibodies here. The allergen comes and binds to the IgE antibodies. There is cross-linking that happens, and when that cross-linking happens, you have inflammatory chemicals that get released, then causing your symptoms. So in terms of the management of anaphylaxis, ABCs always, epinephrine, oxygen, IV fluids. You want the patient to be in a supine position, laying flat, and 911 must be activated. Epidosing is important to talk about. 0.01 milligrams per kilogram for children, up to 0.3 milligrams. We used to say 30 kilograms was our cutoff for when you would prescribe EpiPen Junior versus a regular size EpiPen. But now we're leaning more towards 25 kilogram cutoff, especially in a child who has multiple risk factors for anaphylaxis. IM versus sub-Q, very important. Always should be given intramuscularly. You can see here that the time to peak plasma epinephrine concentration with subcutaneous epinephrine is much longer compared to IM dosing, 8 minutes versus 34 minutes. So IM is the preferred route. How to use the EpiPen. The patient should be lying down. Proper hold is as seen here. This is an older EpiPen. We'll show you a newer one, what it looks like. But you want to hold it this way, needle here. This is what happens when you stick yourself. This is a picture of a person who accidentally held it the wrong way and got a bone fracture from it. And 16 to 35% of individuals need a second dose, which is why oftentimes you're prescribed more than one 2-pack so that you have more than one on hand. These are the auto-injectable epinephrine devices that we have currently: EpiPen, Twinject, Adrenaclick, Auvi-Q, and generic epinephrine is also on the market. This is Twinject. This is an older EpiPen model. We'll show you the newer one. This is the newer EpiPen model. And this is the Auvi-Q. The Auvi-Q is the most recent one that has come out on the market. This is a study that was published recently looking at patients' preference for Auvi-Q versus EpiPen. EpiPen, I would say, is the one that's been prescribed the most. And you can see across all of the parameters, patients prefer the Auvi-Q. The problem with Auvi-Q, though, is that it is not necessarily covered by all insurances at this point, but it is smaller, and it also talks to you. It will talk to you and walk you through the administration of the epinephrine. Now we're going to talk about venom allergy, Hymenoptera venom allergy. The incidence of anaphylaxis in children is about 0.3 to 1%, so not very high. The stinging insects that we usually test for are honeybee, yellow jacket, wasp, white-faced hornet, yellow-faced hornet, and fire ants, which is more of a problem in the southeastern United States. So honeybee is the most severe of the anaphylactic reactions, and it's a longer-lasting reaction. Yellow jacket, however, gives the most reactions, partly because yellow jackets are more aggressive. And the fire ants, when you do get stung by them, can lead to small pustules, as you see here. The clinical history is very important. Skin tests are more specific than the serum venom specific IgE, so you should refer in to an allergist for skin testing. But no, the skin test can remain negative for 4 to 6 weeks after a sting. So if there's a convincing history of anaphylaxis to venom with a negative skin test and serum-specific IgE, the recommendation is to wait at least 6 weeks and then repeat the skin test and the serum-specific IgE. And then, if negative again, we would still probably prescribe epinephrine as a safety precaution. Tryptase is not always positive, and family history is not relevant. So how do we manage based on sting reaction? This is very important. This was a paper that was recently published in the New England Journal of Medicine in 2014. And they looked at the different types of sting reactions: large local reactions, cutaneous systemic reactions, so hives, and full-blown anaphylaxis. And they broke it down into 2 groups: children, less than 16 years of age, and older adolescents and adults. And so you can see here that if you have a large local reaction with a sting, there's no further workup that's recommended for either children or adults. If you have cutaneous systemic reaction, so you have hives, no further workup is recommended for children less than 16 years of age, because this cutaneous systemic reaction is not predictive of severe anaphylaxis. However, in older adolescents and adults, we would recommend diagnostic testing and immunotherapy if positive. And obviously for severe anaphylaxis, diagnostic testing and immunotherapy for both groups. So anaphylaxis from Hymenoptera. Venom immunotherapy can prevent anaphylaxis from a subsequent sting in about 95% of venom allergic patients. So very important if patients are truly allergic to venom to start them on Venom IT. When do you want to discontinue? You want to discontinue after completion of 3 to 5 years of therapy, if there's negative skin testing and or negative venom-specific IgE testing, if there's a negative sting challenge test while on therapy. When do you want to consider lifelong treatment? So if the patient has had a near-fatal systemic reaction following an initial sting, honeybee seems to be the one that causes it, more so than vespids. If the patient has an underlying mast cell disorder, if there is positive skin testing after 5 years of venom immunotherapy, and if while on immunotherapy the patient develops anaphylaxis, that's a sign that they are not cured yet. This was a paper looking at the outcomes of Venom IT in children. And so here on the left you have, these are honeybee allergic patients and vespid allergic patients who are receiving immunotherapy. And you can see here that the percentage of patients with systemic allergic reactions with a sting subsequent to starting immunotherapy was much higher in the honeybee group versus the vespid group. Low, but still higher than the vespid. Here, you're looking at the persistence of systemic allergic reaction upon restings in relation to age at diagnosis. So these patients are on immunotherapy. They get restung again since being on immunotherapy. And you can see here that the younger kids, less than 10 years of age, very rare to have an allergic reaction, a systemic allergic reaction. But the older kids have a higher likelihood of maybe having more of a systemic allergic reaction despite being on Venom immunotherapy. Other pearls. So local insect sting reactions, you would want to ice, give antihistamines for itch, and if warranted, systemic steroids for 3 to 5 days. Know that honeybees leave a stinger, so there's a stinger on the skin still after the child has been stung, and it's likely a honeybee. And there's no allergy testing or treatment for fleas, mosquitoes, flies, or other biting insects. Now we're going to talk about adverse drug reactions. And so adverse drug reactions cause approximately 75,000 to 100,000 deaths per year. The true IgE-mediated sensitivity is only about 10%, however. We can break up the reactions into two groups. There's the type A and the type B. The type A are more common, predictable reactions, toxicity, side effects, secondary effects, drug interaction. The type B is less common and unpredictable. You have intolerance, idiosyncratic reactions, hypersensitivity, and pseudoallergic. We're going to be honing in on the hypersensitivity reactions. In terms of risk factors for drug hypersensitivity, higher dosing of medications can lead to hypersensitivity. IV administration has a higher risk. Large molecular weight agents, frequent repetitive courses of the medication, female gender, and age. It's less frequent in infants and elderly. Atopy is not a risk factor for small molecular weight agents such as beta-lactam allergy, but it is a risk factor for latex allergy and radiocontrast media reactions. A family history of a reaction to a specific drug does not increase your chance of reacting to the same drug. That's another important point. So the clinical presentation would be the same of any anaphylactic reaction, urticaria, angioedema, respiratory distress, etc. There are many causative drugs, biologics, and also drug excipients, but it's commonly due to beta-lactam antibiotics, especially in the pediatric population that we're dealing with. So the penicillin antigens, we break down the antigens into major determinants and minor determinants. And we do penicillin skin testing in the office. Major determinants, we have a pre-pen testing, which is a commercially prepared skin testing extracts that include the major determinant. And then the minor determinants include penicilloate, penyloate, and penicillin G. Unfortunately, the minor determinants are not commercially available, and so we don't have skin testing extracts for this part of the penicillin drug molecule. 90% of patients with a history of penicillin allergy will eventually tolerate penicillin, so that's important to know. And approximately 80% of penicillin allergic patients lose penicillin IgE after 10 years. I just want to give a quick word on amoxicillin and ampicillin. So both of these antibiotics are associated with the development of a delayed macular papular rash in about 5 to 10% of patients. And we believe that this is not due to the major or minor determinants, as we just pointed out, but probably due to R group side chains. So when you do penicillin skin testing in this subgroup of patients, their tests will be negative. So it's not IgE mediated, but if they continue to ingest the amoxicillin and or ampicillin, they will have a delayed reaction. Now, cephalosporins and penicillin allergy. They share a common beta-lactam ring, as you can see here. There is cross-reactivity with the first generation cephalosporin and penicillin, about 6 to 10%. And there is cross-reactivity with penicillin and second and third generation cephalosporins that are less than 2%. And if a patient is penicillin skin test negative, they may receive the cephalosporins safely, and that's another important point. And if you are worried about a patient who has penicillin allergy, best bet would be to go with a second, third, or fourth generation cephalosporin. Now, the negative predictive value for penicillin skin testing is approximately 100%, so that if it is negative, we are fairly certain that it's negative. And that's skin testing to pre-pen. and the minor determinants. But as I said to you, we don't have 2 of the minor determinants as commercially prepared extracts. And so there is a 10% chance that you may be missing the penicillin allergy in these patients because they're only reacting to the penicilloate or penaloate. And for that reason, when you refer in a patient to our office for penicillin skin testing, we will do an amoxicillin oral challenge in the office as well, just to confirm that they're not allergic to these minor determinants. If penicillin is required in a patient with positive skin tests and there's no other alternative, we would then suggest desensitization. And there's no standardized skin testing for non-penicillin antibiotics. Penicillin is the only antibiotic where there is good skin testing. A negative skin test does not rule out the possibility of an immediate type allergy as well when you're doing non-penicillin antibiotic testing. Now, I wanted to talk about urticaria and angioedema. This is the last topic that we're going to be touching on. Urticaria and angioedema is erythematous swelling of the superficial skin. It occurs when blood plasma leaks out of small blood vessels into the skin, and this is mainly due to histamine release. It can occur in response to a trigger, and it can occur anywhere on the body. And the symptoms that we usually find are itching, burning. Worst case scenario you can get systemic reactions such as flushing, throat swelling, wheezing, and diarrhea. Now, if the histamine gets released in the superficial layers of the skin, you get the urticaria. If it gets released in the deeper layers of the skin, you get angioedema, which is swelling. The face, the hands, the feet, the groin areas are common areas for angioedema. It affects 20 to 25% of the population at some point in their lives. If there is remission, there is remission in less than 1 year in 50% of patients. But if it lasts more than 6 months, which it does in about 40% of cases, then these patients are the ones in whom it will last likely more than 10 years, unfortunately. We break up urticaria into acute and chronic, so less than 6 weeks and greater than 6 weeks is our cutoff point. For acute urticaria, there are different triggers than what is found in chronic urticaria. Foods, drugs, namely NSAIDs, insect stings, latex, are common reasons for acute urticaria. Inhalant allergens. We do have children who are severely allergic to pollens, and if it's tree pollen season, let's say, they sometimes will break out in some hives for a few days or so. Viral infections, very, very common trigger in children, especially the younger children, toddlers, infants. And then we have idiopathic causes. Chronic dermatographism. So if you have super sensitive skin and are dermatographic, which is hives upon stroking of the skin, you are more predisposed to having chronic urticaria. Cholinergic. There are cholinergic causes, and so exercise, heat, stress, anxiety are some of the cholinergic causes. And then we get into the physical urticarias, which are due to extreme temperatures, pressure, aquagenic, and solar. Extreme temperatures would be cold-induced urticaria, heat-induced urticaria. Cold-induced urticaria, just one word on that, that can become systemic. For instance, if a child jumps into a large body of water, the lake, the ocean, an unheated pool, and has total body immersion, there can be complete histamine release, which then leads to systemic anaphylaxis. And so for those patients who also tend to have cold-induced anaphylactic type symptoms, we will prescribe EpiPens. A water temperature above which they can tolerate, 77 degrees Fahrenheit. Pressure, very rare, but can happen. Aquagenic, these are patients who come into contact with water and they break out in hives. Solar, also rare, but they come into contact with sun exposure and they break out in hives. Then we get into autoimmunity. There is some school of thought that possibly autoimmune antibodies could be triggering the skin to release histamine. And then there are idiopathic causes as well. So a word on chronic urticaria in children, very rarely associated with food allergies. We get a lot of referrals into the office for chronic urticaria, and oftentimes one of the things that they want tested is food allergies, very unlikely. Empiric food elimination diets are not recommended in chronic urticaria. Chronic urticaria is less likely to be associated with an identifiable cause, which makes it a very frustrating disease. And oftentimes, thyroid autoantibodies can be frequently identified. However, if a patient is euthyroid with thyroid autoantibodies, we don't know what the meaning of that is, and so there is some controversy about whether or not thyroid autoantibodies play a role or whether we should even be testing for this. Food allergic urticaria, very clear-cut presentations. I just want to touch upon this. It usually occurs within 15 to 30 minutes after food allergen ingestion, up to an hour. It doesn't appear the next day. So if you're worried about chronic hives and you think it's food-induced, it likely is not food-induced if the hives are occurring on a daily basis if you stop the food. It's reproducible, and spices, dyes, preservative allergies are very rare causes of food allergic urticaria, especially in children. Idiopathic urticaria. So this accounts for greater than 75% of chronic urticaria cases. Why is this? Is it an autoimmune origin? Is there a role for IgE receptor antibodies? Not sure. We don't really know, but they get clumped into a class of idiopathic urticaria, and they're treated basically the same way. I want to talk about cholinergic urticaria more specifically because this is something that we do get a lot of, we find a lot in children, especially children who play sports or very active. The hives that you find in cholinergic urticaria are not your typical welts that you see. They're very small, about 3 to 4 millimeter size papules, macules, very, very intensely pruritic, and seems to occur after showers, hot showers, heat, exercise, stress, and anxiety, and may also occur with wheezing. So just keep that in mind if you have a patient who's coming in with chronic hives, but the hives don't seem to be your classic welts. If they look like this, they're probably cholinergic urticaria lesions. So the diagnostic testing for acute, depending on the story, if you think it's a food allergic reaction, antibiotic allergic reaction, you would do skin and/or serum-specific IgE depending on the history. Extensive evaluation for specific viral pathogens are not indicated. For chronic, we like to limit testing because we know that extensive laboratory or skin or specific IgE testing to inhalants or foods are not cost-effective and not very helpful in making a diagnosis. Some baseline labs that could be sent off, CBC with differential, inflammatory markers such as ESR, CRP, liver enzymes, thyroid testing, and there are also these commercial assays that are now available for IgE receptor autoantibodies. We don't know what the implication of these autoantibodies mean, but we do the testing, and if it's there, it could give you some sort of idea that maybe there is some autoimmune basis for the chronic hives. Skin biopsies are not usually required in most cases, except if you're worried about urticarial vasculitis. Now, in terms of step-up treatment for the treatment of chronic urticaria, this was recently published in our Journal of Allergy and Clinical Immunology. It goes through the basis of treatment for chronic urticaria, which can be very frustrating to treat in some cases. You definitely want to start off with a monotherapy with a second-generation antihistamine, such as your Zyrtec, your Allegra, Claritin. You want to avoid any triggers that could worsen the chronic urticaria, such as NSAIDs or any relevant physical factors. If that doesn't work, then we move on to the step 2, which is advancement of the second-generation antihistamine. So instead of doing once daily, increasing to twice daily, or maybe adding another second-generation antihistamine, so Zyrtec in the morning or Allegra in the morning and Zyrtec at night, and then also adding an additional H2 antagonists, such as Zantac, ranitidine, a leukotriene receptor antagonist. Some people have found benefit with that. I really haven't. And then adding a first-generation antihistamine to be taken at bedtime. So this would be your step 2 moving up approach. Step 3. So if they're not being controlled with this regimen, you could advance the older generation antihistamines, the more potent ones, such as hydroxyzine or doxepin. So you can add that on to see if that helps. And if despite all of that, that doesn't work, then you may want to start thinking about adding an alternative agent, such as omalizumab or anti-IgE, cyclosporin, Plaquenil is another one that we sometimes use. There are other anti-inflammatory agents, biologics, etc. Now, omalizumab, as you all know, is approved for the treatment of allergic asthma, but it was recently approved for the treatment of chronic urticaria. And so this is a nice study that was published in the New England Journal of Medicine a year ago, looking at omalizumab for the treatment of chronic urticaria. Here we see the itch severity score here. They had omalizumab 300 milligrams monthly, 150 milligrams monthly, 75 milligrams monthly, and a placebo. And you can see that with the 300 and 150 especially, there was significant reduction in the itch severity score after administration of 1, 2, 3 doses of omalizumab. Here we're looking at the number of hives, and similarly, you see a significant reduction in the number of hives with omalizumab 300 milligrams, 150 milligrams, even the 75 milligrams compared to placebo over the course. And this was all statistically significant. So this is a new indication for anti-IgE and one that we're using more often in our very difficult to treat chronic urticaria patients.